All right, we're back. And by we, I mean me and Dr. Rabkin here.
Yeah.
It's so weird calling you that, but that's a different story. Don't get used to it. Okay, so I've kind of decided that we're going to do something a little different. I know everybody's used to all of the chaos that we bring with me and Kayla. We're going to switch directions here for this specifically, and we are bringing it to the audience. I brought Dr. Rabkin on here today because we are going to be answering some questions that a lot of women have about hormone replacement. Now, that episode that we did drove a lot of questions. I have them here. So we figured, what the hell, why not? Let's ask them.
Yeah, thank you for having me. I guess you're desperate enough to want to bring me back.
It's because you know this stuff and I don't. That's why.
Let's go with that. But no, thank you. It's fun being back here.
All right. So I polled the audience. Now, the last clip, like I said, I actually sent it out to a few of the women's groups in the local area. Some of them are unfortunate or fortunate enough to have me as one of their admin people. And it's actually one of the largest groups in Northern Virginia that is specifically for women.
Cool.
Yeah, it's got close to like 48,000 people in there, like women in there. So
Impressive.
I know. Sometimes I do good things. So they have, on a daily basis, I see a bunch of questions about hormone replacement. And it's just like, you know what? It's easier. Let's just ask the doc. So we're doing a new thing where we just ask the doctor questions. And they came up with some pretty good ones. All right. So here we go. You ready?
Should I maybe do a quick intro into women's hormones?
You should.
Yes, let's do
You
that.
should. That's probably a good idea.
Before we go into questions.
For those who missed the last episode, let's recap.
Just a quick recap. So there is a really good revolution right now in women's hormone replacement therapy, specifically talking about menopause, perimenopausal symptoms. I think for several decades since the 90s, women essentially were not given any hormone replacement. They were told, you know what, menopause is normal, suffer with the consequences.
I mean,
I'm being a little facetious, but that's kind of how it went down.
Yeah.
Prior to the Women's Health Initiative, many women were getting hormone replacement. A lot of the docs I spoke to were doing it, and then overnight, essentially, that just changed because the Women's Health Initiative said, this is dangerous, women are going to get cancer. Now, there's a lot of issues with the study, the way the statistics were reported and claimed how many women are actually getting cancers, really different from the reality of what the study actually showed when you get into it. In reality, the main thing is that the increased risk of breast cancer in an average woman, what I mean by average, someone who's not high risk already for breast cancer, doesn't have a long list of family members with breast cancer, hasn't had breast cancer themselves, kind of the average woman walking around, the baseline risk is about 12% of getting breast cancer in their lifetime. With combined estrogen and progesterone, and that's important, the WHI showed that the risk went up by 8 in 10,000. So that's 0.08%.
That's actually not bad.
Not still a risk.
Right.
They're right. There was a slight increase, but it is with the combined.
But there's a risk with everything, like no matter what you take.
Risk of everything. And that's the thing. They completely missed the risk benefit. So many women are suffering. Yeah. And it's not just symptoms that women feel. With menopause comes bone mineral density loss, insulin resistance,
there's a bunch of stuff.
Emotional issues.
Getting attacked.
So no. I mean, palpitations, migraines, so many things can develop that can impede your quality of life and actually impede your longevity of life. Fracture risk's huge. So that wasn't always factored in, and now we're seeing improvements in how that study was interpreted, new studies coming out, and we have better medication. So this, I think, conversation is kind of about what we really know, what we don't know, and kind of the current practices. And when it comes to those questions, because I pre-read the questions to prepare, got to cheat a little bit.
I had to mentally prepare him for what we were doing.
Of course. In science and medicine, it's not always going to be straight answers, and it's frustrating for everyone.
Yeah.
So even though there's a lot of questions and I have some good answers, some of those answers may not be black and white. So I apologize. That's the nature of things. That's the art of medicine. Still, there's still so much more to figure out, but I'll try to make it as practical as I can.
Well, I think the other thing also is that each person responds differently. It's not just like the science behind it, is that each person's going to respond differently to treatments and medications and what have you. It's not one shoe fits all.
No, not at all. And I think that's the other great take-home message. There's no one size fits all. Everyone's going to have slightly different. Even the kind of symptoms women feel in menopause, perimenopause, it's a laundry list. And some women feel all of them, some none, and to various degrees.
Yeah.
And when we talk hormone replacement and menopause, it's not just estrogen. Testosterone plays a big role, and progesterone.
Yeah.
And maybe should I do a quick science of what's happening?
Can we fix your mic first? It was bugging me.
We can.
It's flipped upside down.
Oh.
Okay, there.
There we go. There we go.
Don't worry, I'll edit that out.
So what is perimenopause, menopause? So perimenopause essentially is your ovaries are still producing your hormones, estrogen, progesterone, testosterone, but it's fluctuating. It's not as smooth. It's not as clean as it used to be. The levels aren't the same. As that progresses, women are having irregular periods. So some months they're having a period, some they aren't. And that relates to some months good hormone levels, some months not good hormone levels. And over time, the ovaries just flutter along and stop producing it. And that's when we get menopause, where essentially there's really no more hormone around. Estrogen, progesterone, and testosterone essentially gone.
Stop.
And that's a really simplified explanation of what's going on.
All right. Should we get into the questions?
Let's do it.
All right. What I should have done was put them in kind of an order to this, but let's just dive right in.
Let's just do it.
All right. Question number 1. Can you take it at 61?
Great question. Yes. Assuming that question implies that they've gone 10 years past, the average age of menopause is about 51. So I'm assuming that's where that question comes from.
Damn
it is what?
I was like, damn it, I still have to wait.
Still got time. Short answer, yes. It's never too late to get the benefits of hormone replacement. Strengthening your bones, improving your mental focus, improving your insulin sensitivity. It's never too late. The studies do say that there is a benefit in starting earlier, much higher benefit.
Okay.
And there's even a slight benefit early on in reducing your risk of breast cancer, actually, by doing hormone replacement. Early on, there's some data about estrogen helping with that. Stay tuned for more and more studies on it. So the earlier, the better, but it's never too late as long as you're normal risk and there's no other variables to really reap the benefits from testosterone, improving your libido, improving your energy, improving how fast your muscles are degrading. And that's huge as we get older.
Yeah. I think especially for women, because with the osteoporosis factors and all that.
The rate of muscle loss is extreme as we get older, and for women it's a little faster and already starting at a lower muscle density to begin with. So never too late. Please talk to your docs. And
I think that's the other thing. Please make sure you talk to your doctors.
Yes.
Just because we do this doesn't mean that you should take all of our advice here, okay?
Yeah. There's so many variables and nuance to an individual person that sits in front of me that the decisions, it's not a blanket protocol. It can never be.
Yeah. All right. Which ones are the most natural and safe to take / use?
In terms of hormone replacement?
Yeah.
So I think that maybe that question goes towards synthetic, bioidenticals. So let's talk about what bioidentical first is. Bioidentical does not mean natural. Bioidentical just talks to the chemical makeup, if you remember chemistry class and all those hexagons, pentagons, right, of carbons. That's what we're talking about. Bioidentical medicine essentially looks exactly like the hormone that your body produces. That's bioidentical. There are FDA medications coming from pharmaceutical companies that are bioidentical. That maybe doesn't mean they're quote unquote natural or derived from a natural plant source. Some of them can be. Synthetic just means that there's something slightly different in the way the hormone molecule looks like compared to the original one your body produces. The there's really no research or robust research showing that the natural bioidenticals are better. There's theories, there's some docs out there that say it should be better, it should be safer, less side effects. But sitting here, I can't say that with certainty without seeing the data.
It's fair.
So, yeah. So that's kind of one of those answers that doesn't really answer the question, but that's just the reality.
We need more data.
We need more information. We need more research. That's going to be my default answer. We need more research.
Need more
That's
research.
my cop-out answer.
No, and you know what, though? I'd rather hear that than somebody try to pull something out of a hat and just kind of not necessarily make up an answer, but almost tell the person what they want to hear.
Yeah, I get that. And both can be safe. Like the bioidentical pharmaceutical grade ones, like some patches, great. When we talk about compounded medication, some of those bioidenticals also can be great. Since we're sort of on the topic, the compounded versus FDA approved. So the FDA approved medications, right? There's a minimum quality standard that they all have to go through. So there's some trust. Is there issues with the FDA? Conversation for another podcast.
Right.
But there's at least a minimal understanding of these are tested. We know they have to go through rigorous quality checks. Not all compounding pharmacies have that.
Yeah.
That doesn't mean all of them. There are great compounding pharmacies, 503A, 503Bs, that go through intensive internal, external quality control, and I trust them. The ones I use, I make sure I get their certifications, I follow up with things. So if you are going to do the compounded, which saves money for some people, not everything's approved through their insurance, especially testosterone in women.
That's the one that surprised me.
Yeah, it's a black. Yeah, that's a whole nother story. Yeah. That's being fought. But yeah, compounding builds better access and more affordability for people who either don't have insurance, it's not covered for XYZ reasons, but it's definitely a good resource to have.
So with that, I guess make sure that that's a decent compounding pharmacy, not just Harry off the street.
Exactly. Make sure the provider that you're doing trusts them, that they're reliable, they've gone through the quality controls, and the provider that's using that, working with that compounding pharmacy, knows that.
Okay. Yeah. All right. You ready for the next one?
Let's do it.
All right. This is going to be like a two-part. What can be done for brain fog?
Yeah.
And ADHD and brain fog, are they associated with HRT?
So depends. So brain fog is definitely a symptom with perimenopause and menopause. Just that mental focus can change. And ADHD is a very specific medical diagnosis, right?
Yes.
A lot of people who lack sleep, have thyroid issues, poor nutrition, stressed, lack focus. Like some days I just can't focus on what I'm reading.
Happens a lot.
Right? It happens.
Not you, me though.
Yeah. No, I know what you mean. I know. You've been tested for ADHD. But ADHD is the diagnosis or syndrome. Not being able to focus is a symptom.
Okay, yeah.
And that could be explained by a lot of things. Yes, definitely can be explained by hormone changes and hormone irregularities. Yes, hormone replacement can help with it. Is it a guarantee it will? No. Because like I said, nutrition, sleep, stress, thyroid, all other could factors also cause that too. So before just jumping on any hormones, make sure the provider you're working with is doing that evaluation and ruling out other things that could cause, because that's super important.
Yeah. And I think that's the other thing is a lot of people, again, are relying on TikTok and Instagram for, if I have these symptoms, this must be what it is.
Yeah.
So I'm going to start taking these meds.
Yeah. So you have one TikToker saying if you can't focus, it's that you need this supplement, and others talking about sleep, and others talking about, I don't know.
Which, I mean,
grounding,
I guess.
Who knows?
Walk outside barefoot, ground yourself.
Look, there's one symptom can be explained by so many different illnesses, conditions, lifestyle things. Why we have providers to help you, why we train for decades to be able to tease that out.
Yeah. Christ almighty. All right. Let's see here. See, this is where I wish it would, because we're gonna be jumping back and forth here, but this one here, I love an honest take on the necessity of taking multiple supplements alongside HRT to truly see results. Basically, there are so many books and doctors on social media recommending a long list of supplements to complement HRT and help minimize perimenopause symptoms to feel normal again. They want to know what your perspective is on this and whether supplements are actually needed or if HRT alone can be effective.
Yeah. Great question, actually.
Right?
Very
I'm telling
good
you,
question.
these ladies did not disappoint.
Yeah, no. I mean, there's so much info. I mean, everyone's confused. So supplements have a place in very specific conditions. I don't hate supplements. I don't love supplements. They're just another tool, right? There's tool for everything. And just gotta need to know when to use it. So I'll kind of maybe split it up and answer part of a question that wasn't even answered. Some people, even before going on hormone replacement, will try supplements.
Yeah.
Right? There's your ashwagandhas, some certain mushrooms are touted to improve testosterone and things like that. DIM.
That kind of mushroom, got it.
Different kind of mushroom. Different
yes.
journey. These supplements may have some effect. When it's done in the laboratory, either animals, petri dishes, yes, the science shows there can be some effect.
Okay.
The problem is the amount of that effect. So people will see ashwagandha, increased testosterone levels or is calming or whatever. Yes, technically that might be right, but then they translate it to humans where the effect may not be huge. So for a healthy person, normal hormone levels, using some supplements, maybe we'll squeeze out a little bit more or improve some levels here and there. Maybe. There's no great research on it. When it comes to full perimenopause, menopause, where your hormones are just not functioning that way, those supplements aren't going to fix those problems. It's just that
it's just such a small dose that
exactly.
Okay.
It's a drop in a bucket that is hormone replacement when you need it. So compared to hormone replacement, the supplements aren't going to do a thing and probably won't do much for someone truly suffering from estrogen deficiency or testosterone deficiency. There are certain cases when you're using hormone replacement therapy, especially in the beginning to help with some side effect issues in the beginning, that some of the supplements like DIM, for example, I use can be helpful. Usually people don't need them after a while. Some will take them because they just need that balance. Like DIM helps balance out the conversion of some of the estrogen and testosterone to a few things and helps balance out the good and the bad. That's an oversimplification of what happens.
Okay.
And in those situations, it can be used. But needing a stack of supplements on top of hormone replacement therapy, not needed. It's a waste. It's definitely a waste. There's a small use, but you generally don't need all those supplements. Someone's trying to sell you something.
So would that be safe to say, like, if you're like in the depths of it and you're really struggling with all these symptoms, you're saying supplements are going to help or do much? But what about like the early on? Like if you're just like, if they're more of an inconvenience, like the symptoms that you're having is more just annoying and you just want to stop that.
Yeah, maybe, right? Then that comes down to the individual. How inconvenient, how much of a deficiency of your hormone you're having. It's a really hard question to answer. Because those supplements are going to maybe do a little bit, and don't forget the placebo effect.
Yeah,
always there.
It's always there.
Yeah, especially if
you have girlfriends that are saying, "Oh yeah, this helped for me." You're like, "Yeah, you know what? I think it helped for me too." No,
it can happen. So early on, maybe, but I'm saying maybe because I just don't have any strong research that those supplements make a great impact.
Okay,
so that's where I can't say. What I will add, I don't know if this was a question or maybe it was, what non-pharmacological stuff can be done? I don't know if that was a question.
No, but I'd love to know the answer.
Yeah. So there's some data on lifestyle stuff that can help with early
Oh, you know what?
symptoms.
That was on here somewhere. Yeah, there was. Lifestyle changes that'll help significant impact on perimenopause and symptoms and severity. Yeah. There was that. Okay.
Yeah. So there's always been things like maintaining weight can really help with the hormone balance. Obesity and fat tissue, those cells actually convert hormones, and when you have too much, it could cause a lot of problem in men and women with the balance of good, bad hormones, like the good versions of estrogen, testosterone. So being in a healthy weight. I'm not talking about super, super lean like you're about to compete. But being in a healthy weight can improve some symptoms, especially if you're already at a higher weight area. Can I guarantee that someone who's suffering and is overweight loses weight is going to feel a lot better? I can't, but the data says some percent might.
It's beneficial.
Increasing muscle mass actually really helps balance hormones and helps with symptoms. Activity in general, being physically active and eating healthy will help. Getting good sleep hygiene will help. So
like
kind of all the stuff that we tell you, diet well, exercise well, all that can help. Someone who's in menopause where the ovaries are just not working anymore, it may not make a huge difference for all people. But again, some women don't have major symptoms. And in part, it could be that they're lucky. In part, it could be because they're doing all those other good lifestyle things. But someone who does all the right things I've seen can suffer from all those symptoms. So there's no guarantee, but those are good things to try regardless.
Just to be healthy.
Yeah.
Like just to be healthy.
It helps feel better.
Right. It will help you feel better. Okay. I will say that. Let's see here. What indicators should we be looking for to let us know it's time to see an HRT specialist proactively? Hopefully before we spend years of suffering being told that everything is normal, or what is actually normal, and what are the indicators of actual concern and need for help?
Yeah, so good question. Also difficult one to answer because, like I said, one woman's symptoms are going to be different from the next. Going to be different from the next. The severity, which ones they're doing. You have the common symptoms of estrogen deficiency. So your vasomotor stuff, your hot flashes, right? I've been told.
Suck.
Severe, significant brain fog, all of a sudden more fatigue that's unexplained, decrease in endurance. I've had one patient who was super fit, super active, and kind of hit a point where she just wasn't able to lift the same weight in the gym. Her muscle recovery was shot, and that was her. But she was already doing this, and there was no other reason to explain that change. That was her sign. Something was going on. Feeling different. All of a sudden, emotionally unstable. There are definitely cases of women who later in their 30s, 40s develop signs and symptoms, what looks like anxiety and depression.
Yeah.
For no reason. Like nothing's changed in their world. And that could be it. But again, that could just be anxiety, depression too. That's the difficult part about diagnosing. So anytime you feel something different and it's interrupting your quality of life, talk to your doctor. But no, it may not be hormones. It could be. Hopefully the physician at least thinks about it and you have the discussion, especially if that's something you're worried about. They could get the labs and discuss. Yeah. When you're menopausal, it's kind of easier on the lab work because the hormones are gone.
Right.
When you're perimenopausal, some months the hormones will be good, sometimes they won't. So it's really symptom management. That's really what's done in hormone replacement. It's kind of support in perimenopause versus replacement in menopause. So it is tricky. What's even harder sometimes is for women who experience these symptoms at a much earlier age than expected.
Yeah.
So perimenopause, late 40s, sometimes early 40s, but there are cases of premature ovarian failure with women in their 20s starting to go through perimenopause, which is so hard because I understand a 20-something-year-old comes in, perimenopause wouldn't be on the top of my list. No. There's so many other things. It's just not expected. It's rare. But when all else fails, talk to the doctor. Hormone check, while not part of a standard panel, is not unreasonable if other things are showing up normal.
Yeah, it's not. It's not one of the things that you would think of.
Yeah. So this was one of those questions where there's no great answer. It is tricky, but having a provider you trust that listens to you, that doesn't just shoot things off, is key. And that's hard to find. I know that. I know that.
That's why I bring you on here.
Happy to be here.
Because they ask questions and I bring the doctor.
Let's do it.
But I think another thing, though, with that is a lot of women they put themselves last. So they don't pay attention to those changes that their bodies are going through until it gets to the point where it's not manageable anymore. And then they go and see a doc, and I'm just like, well, so pay attention, ladies.
Yeah, it's
hard.
Tough. It's tough. Taking care of ourselves is hard, especially for women, doing so much. And we just like, oh, I didn't sleep. Oh, I'm dehydrated. Maybe, but maybe not. So there's a balance of taking care of yourself and not blowing everything. You're fine.
I know I am. It's fine. It's my life motto. It's fine. Everything's fine. I'll be
just
fine.
Have snacks.
Yeah, it's fine. This one was one that I wanted the answers to also. Why is it that some doctors prescribe testosterone along with estrogen and progesterone and others don't?
So testosterone, as of right now, is still considered a controlled substance. So in the same line as your anxiety medications, your oxycodones, different category, but controlled. So people are scared to do it. So this is my opinion. I think some providers just don't think testosterone when they think women.
Yeah.
Which is incorrect. Men have estrogen too. Women have testosterone. Mm-hmm. And actually the peak testosterone levels in a healthy female is just about the same as the peak estrogen levels in a healthy female.
Oh.
Same amount of levels.
Did not know that.
Yeah. And the nuance and stuff comes in, like who has how many receptors and how sensitive are those. That gets way too technical, but that's part of the reasoning. But technically your body produces lots of testosterone. And we weren't trained to think of it. Some early on when research in hormones was done, I think 80s, 70s, I'm blanking, don't quote me on that. It sort of was done estrogen for women, testosterone for men, the end.
Yeah.
And that sort of got built into the dogma of medical education, but that's not the case. So some providers are afraid to give testosterone to women. Some aren't thinking about it. Super important with the right symptoms. We talked about estrogen deficiency, but testosterone deficiency can cause decreases in libido. Clitoral insensitivity, which is a lifestyle thing, can contribute to insulin resistance, which is the beginnings of diabetes, where your body just builds up high sugar levels. So there's a contribution there. Cognitive issues too. Sometimes sleep. Often we use progesterone for sleep, but I've had cases where it really was the testosterone that helped more. They were just lacking it. So I think those are the two reasons, in my opinion, that some providers don't use testosterone. There might be others. I could probably missing a few, but those I think are the ones that come to mind.
I think you pretty much nailed it on, whereas they don't think testosterone women.
Yeah.
They're just, we don't do that. All right, let's see here. I like this one. How to help women who are breast cancer survivors and have been told over and over by doctors that you cannot take HRT and are struggling with perimenopause.
Yeah. That's a huge and tough one. So there are contraindications where some women just shouldn't be on hormone replacement therapy. Active breast cancer, active gynecological cancers, a few other things too that you should talk with a doctor about. But those are absolute. You shouldn't be on estrogen. Breast cancer survivors get tricky. I think people are nervous because that WHI study still's around. You've had active breast cancer. We just don't know the true effects, so it makes us nervous whenever it has cancer. That's, biologically sensitive to estrogen, progesterone. It makes people nervous.
Yeah.
Now, the reality, or not the reality, what we're maybe seeing is that really it's not estrogen, maybe it's more progesterone. Timing's important. So doing systemic replacement of estrogen becomes hard, and it may not be the right thing for breast cancer survivors. That has to be a very unique discussion to the person. Now, vaginal estrogen actually could be very safe because vaginal estrogen does not absorb systemically and could be safe to use because one of the things that happens with estrogen deficiency is the lining of the vaginal canal changes. It's there's lack of lubrication that puts women at risk for UTIs, pain with intercourse, and in severe cases, when hospitalized, we worry about sepsis, right?
Yeah.
We
Especially the older we get.
Exactly. So in those women who are having discomfort and frequent UTIs, a vaginal estrogen cream could be totally safe, and we know that. I think the black box warning is now being removed, and that in those situations it's good. Testosterone can actually be very helpful in those situations, but I think it still makes a lot of physicians and oncologists very nervous. Yeah. There are some that understand the data and understand where this is moving and have followed the new stuff that are like, yeah, and even though you're a breast cancer survivor with this type of breast cancer, this could help energy, bone strength, right, which would be huge.
Yeah.
But it has to be tailored to the individual, and not every woman's a good candidate for the testosterone in those situations. It's very unique. So that it's a complicated area, but there's still other things that can be done to help.
So she's not suffering.
Yeah, exactly.
Let's see here. Is there a benefit for those with PCOS, and what hormones need to be tested? And is it true that there are more specific optimal ranges than the normal range that many PCPs use?
Yeah, great question. So PCOS is interesting. What is PCOS? To not go too deep, PCOS is a syndrome of different things. Part of PCOS is that women produce high amounts of androgen or testosterone, and it causes other symptoms. It causes issues with insulin and diabetes, but for the sake of time, I'll leave it there. As women go through perimenopause and menopause, a lot of those PCOS symptoms actually go away because the body's just not producing testosterone anymore. Yeah. So some of those symptoms are gone, and then there's other things. There's still weight and other things involved. So in women who have a history of PCOS and are going through perimenopause, menopause, you could still use hormone replacement, but specifically for testosterone, it would be much smaller doses.
Okay.
Again, individualized. So the second part of that question, the reference ranges, right?
Yeah.
So in the past, especially for women, it was just treat symptoms. We don't care about the lab levels. It was just to treat the symptoms. The benefits of the other stuff, the bone resorption, insulin sensitivity, muscle, longevity, other things, they didn't care about. Those are hard to manage, so it was just treat for symptoms. But now we know that there's way more to it, and we do want to treat for certain optimal ranges. Still a debate on what that is. Do we do quote-unquote physiological normals, get you to places where an average healthy non-menopausal woman would be? Or do we go a little bit above that to try to get more benefits out of bone health, muscle health, brain health, heart health, etc.? So I think that's where more research is still needed. Yeah. But discussing that with your doc, finding what works, and that's another one that has to be individualized.
Okay. Makes sense. Injectables versus patches and creams, and why do providers contradict each other? It's frustrating. Yeah. I actually talked to this. I actually did talk to this woman offline, and she did. She had some doctors who were telling her this is the only way to go, and they made her feel bad for choosing to go a different route. Yeah. And I told her, I was like, that's a whole other episode that we can get into. Yeah. I was like, but at the same time, you can't let, as long as they're the appropriate doses for you and then it's the correct medication, you can't let docs kind of bully you into making their decision.
Yeah, to my fellow providers, stop making patients feel bad for their choices. Understand where they're coming from. Explain, communicate. I know we don't always have time.
I know, and that's the other thing.
Their choices. They don't have the nuanced experience you might, or maybe they do. Either way, don't do that.
I know. Please. I was like, oh God. She goes, they made me feel really bad for, choosing one route versus another. Yeah. So they went to go see someone else and they did the same thing. And I was like, what the hell? Yeah,
that's no bueno. Lots of different ways to get hormone replacement. I think having options is important. One option is going to be good for one person, and another option is going to be good for another. for different reasons,
Right.
whatever it is. So patches are great. The transdermals are really good. Generally, from my personal practice, I stay away from oral estrogen or testosterone because those, they have to be processed through the liver and increase certain side effects I really don't want them to have and put people at risk. There's a few benefits from cholesterol standpoint when you do it orally, but for the most part, I like things that bypass the liver, so something that's not done orally.
So you can still drink. No, I'm just kidding.
That's important. That's
Right?
important. People like their alcohol. Whole nother conversation. So having options is important. One option is good for someone and not good for another. So don't make people feel bad about it. Patches are great. I like patches. They're reliable. It's kind of a set and forget it. I think patches are, there's different formulations and how long they last, but they're really good. Creams would be daily, and gels. Also, they have their pros and cons, and I think getting into all that maybe make this podcast a little too long, so I'm going to save that.
So that's okay. We got a few minutes.
So really the pros and cons are either how easy it is to use with gels and creams. Some people absorb it really well. Some people don't absorb it at all.
Interesting.
Yeah. Everyone's skins can be a little different. There's different reasons, but it's daily. Some people like that. Some people hate it. And then depending on how often you use it or the peak levels that you develop in your blood can cause some side effects. With creams, generally not as big a deal, but everything has the potential for side effects.
Yeah.
We could talk about that maybe towards the end. Injectables, for women, it's an option, not always the one we go to. So especially for testosterone, it can be done much lower doses than for men. But with injections, you would be about twice a week. And again, there's different peak levels. So you have to watch out for certain side effects. But some women like it. Some people don't like the creams. And they like the fact that the injection, they don't mind poking themselves. And it's twice a week. It's not that frequent. And it gets absorbed. There's no questions about that. It goes into the muscle. It gets absorbed. Patches I mentioned. Pellets are another option.
That one still boggles my mind.
Yeah, pellets are cool. It's a much more of the set it and forget it. Generally, 3 to 4 months for most women, depending. And it's great. And it gives good levels, tolerated overall well. The downside is it's hard to take out. And once the dose is set, you can't adjust it. You have to kind of wait for it to be resolved. Versus like the creams where it's not working, you could up the cream, change the dose, stop it, right? So again, pros and cons. It's a lot of women I know love pellets. Some it's not a great option for them. And then I mentioned the vaginal creams. There's IUDs for progesterone to protect the uterus. There's different ways of getting hormones in the body when you need it. And again, the main story to take here, or the main point of the story is know the options, know the menu, and understand there's pros and cons to all of it and figuring out what fits best in your life. And you may not get it right the first shot. You may try one thing. It's like, oh, you know what? Actually don't like this, or it's not working. We need to switch to something else.
And it's okay to tell them no.
Yeah. The thing, we talked about estrogen and testosterone. Progesterone is a player here. The one thing I will say, any female who has a uterus, hasn't had it removed for whatever reason, and is taking estrogen has to be put on progesterone.
Why is that?
To protect your uterine lining. So what estrogen does, it increases the thickness of the uterus, gets it ready for having a baby and the ovary to implant. And if you don't have the progesterone come in, take that lining off, and essentially you get a period in a normal situation. Uncontrolled, that estrogen gets thicker. It causes the lining to get thicker and thicker and thicker, and could increase your risk of cancer. Don't want that. So any woman, and if you're taking progesterone, you're fine. But just make sure if you're starting estrogen and you have a uterus and your doctor's not giving you progesterone, be like, where's the progesterone?
What the hell? Right. For women in their 50s still having periods but starting to get irregular, what do you recommend for hormone therapy?
Yeah, so that sounds more of a perimenopause situation where still having periods means there's still hormones going through. It's just becoming more regular. They're kind of puttering out, essentially, for lack of better words.
Puttering out.
Yeah.
That's great.
Yeah. In those situations, if you're having symptoms, you're not feeling like yourself anymore, tired, hot flashes are possible, gaining weight differently, something's different. It's not just your periods are irregular. In those situations, that's what I meant by the support. You're supporting the ovaries, giving hormones, and it would be estrogen, progesterone, testosterone, potentially, depending on what the situation is and the person's history. But those would be the three I'd think about. And it would be more for support. And there you would really treat the symptoms and not so much the numbers.
Right.
And you just watch kind of what happens over time. But if your periods are irregular and you feel fine, like great, nothing different, you may not need the hormone replacement. But at that point, though, you do want to have the conversation of when should I be on hormone therapy, if I should be, even if I'm feeling good, what are the benefits long term for being on it versus the negatives of not being on it? Right. Again, bone health, muscle, brain, all that.
I tried asking her too, but she didn't respond back if it was more of like an irregular period or if like the period portion was still like somewhat regular, but she was having like breakthrough bleeding. She didn't respond back to me. So.
I think it might be because they're at that person might be at an age where they would have expected to already been in menopause, right? The average age is 51, they're 50. Right. But again, it's average. There are women who are going to go through menopause later than that and some earlier.
My grandma was like in her 60s, like late 60s. Yeah. I was like, what the? No.
Yeah.
Absolutely not.
Average is the average bell curve, meaning about 66.2% of people are going to fall in somewhere plus minus that number, but it's not everyone.
The difference between bioidentical versus synthetic.
We covered that one.
We covered that one.
I threw that in for free. You're welcome.
It was in there anyway. Let's see here. I could have sworn there was one more. Oh, hold on. There is one, and I forgot to add it on here. So hold up just a second. Let me find it. Okay. I found the question. We're back.
Let's do this.
Now I got to actually pull it up. What is my phone? There it is. All right. Can hormone replacement help with vestibular migraines or regular migraines, especially during menopause?
So this is going to be sort of a gray answer. It can. Hormone replacement therapy can help with certain kinds of migraines. There are different subtypes of migraines. Some migraines are related to fluctuations in hormone levels. So some women who are going through perimenopause, that phase where the hormones are not as regular anymore, can trigger migraines for them, and hormone replacement therapy could be one option to use to help balance out those hormones and help improve migraine severity and reduce how often you're having it. Again, it's not a guarantee. Migraines can be caused for a number of different reasons. Vestibular migraines, it's kind of a migraine where it's not so much a headache where you're having issues with dizziness, balance, and in perimenopausal women, again, it possibly can be related to low estrogen levels, but it's not going to be the case for everyone's vestibular migraines.
Right.
So again, that's kind of the gray answer of it depends on certain things and depends on the individual. But definitely something to keep on the list of possibilities.
So have your doctor test your levels, your hormone levels.
Yeah, I mean, if you're in that age range, I would check for other signs of hormone deficiency, signs of perimenopause, menopause. But if it's just migraines as your only symptom, still good to keep in the back of your mind, especially if other traditional stuff hasn't worked. It can be a possible treatment for some women.
So there we go. All right. Now we just got to find a men's group that we can ask the guys.
Yeah, I need to look into that. I should. Yeah.
Hint.
I know. I know there's a 45 and up group that I'm part of.
Yeah.
Locally.
Yeah, I got added to that somehow.
I added you.
I was like, wait a minute. How old do you think I am?
I'm not 45 either.
No, I know.
I have some time to go. But yeah, that's a cool idea. I love this whole ask a doctor thing because that's what I'm used to versus just like no one wants to hear what I have to say. They want to hear answers to their questions, and I'm happy to try and give it. Love the format. It's cool.
You're welcome.
Yeah.
All right, so we will be back another day. We've got to schedule something with more answers to some questions.
Yeah, happy to be back. And if you go to my website, synovimed.com,
Yes.
I do publish a blog every so often. Just published one for today.
I got the email. I just finally checked the emails.
All about female hormone replacement. I did a series. But there's other stuff about vitamins, supplements, protein. So yeah, feel free to send an email. I'll put you on the newsletter.
And then I will also include the link to the website and the blogs so you guys can just have a direct link to them. And see you guys next time.
Bye.